Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Ali, who was also here last week for our Cardiology Month. Dr. Ali completed his residency at the State University of New York, Buffalo, followed by a cardiovascular fellowship at the Ochsner Medical Center in New Orleans, Louisiana. He then did his interventional cardiology fellowship at St. John's Hospital in Detroit, Michigan. Dr. Ali is currently practicing in El Paso, Texas as an interventional cardiologist and serves as medical director of cardiology at hospitals of Providence, Sierra East Campus in El Paso, Texas. And now it is my honor to request Dr. Ali to begin today's session again. Thank you.
Hey, good morning, everyone. Thank you for joining us. All right, I am trying to see the presentation. Is a presentation coming up?
No, not yet. I think I need to click share screen, the green button in Zoom.
Yeah. All right. Sorry, it's now are you uploading the slides or do I share it from my end?
We can share on our end.
Yeah.
One second.
For some reason it's not.
There we go. Dr. Ali, do you see our slides?
Yes.
Okay.
It's coming up. Let me see. Actually going to talk briefly about the heart sounds and murmurs, basically cardiac auscultation, and then switch gears about a brief discussion of acute coronary syndrome and the management of ST elevation MI. So basically, whenever you are thinking about cardiac auscultation, there are at least 4 areas that are required for the minimum to complete a thorough cardiac auscultation, cardiac exam. And these are the second intercostal space on the right side is the aortic area, where you actually get significant information about the aortic valve. On the left side, the second intercostal space is the pulmonic area, and left lower sternal border, and like the fourth intercostal space around that is where you actually auscultate for any tricuspid valve sounds. And in between P and T, like the second and the fourth, there's actually an area where you can also hear early diastolic murmur of the aortic regurgitation. And then at the apex, we actually typically auscultate the mitral valve. Now we do auscultate for radiation in the carotids, radiation to the apex, and further into axillary area also. And sometime actually you can actually hear some of these murmurs in the back around the scapula and interscapular areas. In terms of cardiac auscultation, what you are looking for, what you are actually auscultating for is the basic heart sounds, then murmurs, clicks, opening snaps, and venous hums. And they all have their different, reasoning behind them. And they also have a, different implications. There are 4 basic heart sounds. First heart sound, or S1, it occurs in the isovolumetric contraction phase. It is the sound of closure of mitral and tricuspid valves, the valves between the atria and the ventricle. Second heart sound occurs in the isovolumetric relaxation phase. It is the sound of closure of the aortic and pulmonic valve. Third heart sound, it is actually normal sound in children, but in adults, it is an abnormal sound, and it typically represents the ventricular dilatation and stiffening with systolic heart failure, ventricular failure. It can be there. And the fourth heart sound is a heart sound of atrial contraction. Once again, with the normal stethoscope, you cannot actually auscultate it most of the time, unless there is a ventricular hypertrophy and low compliant ventricle, like in hypertension or ischemic heart disease, particularly in this acute ischemic phase. Ventricular stiffness is one of the earliest phenomena that occur when you actually cut off the coronary blood flow. So if you want to actually master the art of cardiac auscultation, forget about everything else and think about S1, S2, the first heart sound and the second heart sound, that is the systole. And the second heart sound and the first heart sound, that's diastole. So between the first and second heart sound, there are no other normal sounds. Between the second and the first heart sound, there are actually S3, which can be normal in the children, but it is abnormal in the adults. And then S4, which is normal if you have augmented auscultation, capability, some of the phonocardiograms. But with the normal ordinary stethoscope, you actually don't hear it. And if you're hearing it, it means it's a louder S4, and it will indicate some sort of ventricular stiffening. The first heart sound has 2 components, mitral, which is M1, and tricuspid T1. These 2 valve closures that generate the first heart sound. Now, these 2 components are actually, in terms of the time scale, they are very close together. So most of the time with just ordinary stethoscope, you will not hear the splitting of the first heart sound. And they're best heard around the lower left sternal border, particularly in the younger people. Now, there are certain conditions that will accentuate the splitting, and you can actually maybe auscultate both components separately. One of them is right bundle branch block. What it does is it increases the time difference between the M1 and T1. And then in certain abnormal conditions like rheumatic mitral stenosis, the leaflets are still pliable and in hyperkinetic state. And then with a short PRN interval, if it's less than 160 millisecond, you maybe actually hear the splitting. Once the leaflets, like in mitral stenosis, where you're actually going to auscultate it more, tricuspid stenosis is seen, but it's much rarer than the mitral stenosis. Once the leaflets becomes more thickened and stenosis gets worse, the leaflets are actually becoming rigid and calcified. Then, other condition like LV dysfunction, beta blockers, and long PR interval, they will actually sort of decrease the intensity of the mitral component, particularly, and S1 becomes softer. Now, other factors will actually muffle the sounds, like if somebody is in a mechanical ventilation, COPD, obese people, and pneumothorax and pericardial effusion, they actually can muffle the heart sounds, and you may not be able to auscultate them clearly. Second heart sound is actually a component of aortic and pulmonic valve closure. It does have normal or physiologic splitting that can be auscultated with the ordinary stethoscope. Now, this splitting becomes more obvious because the interval between the A2 and P2 increases during inspiration because the P2 is delayed, and it decreases during expiration, so it may become harder to auscultate. And this is, again, best heard at the second left intercostal space when patient is in the spine position. A2 is louder than P2. Now, in certain conditions, when there's pulmonary hypertension is present, P2 can be auscultated in most places. You can actually palpate P2 also if there's significant pulmonary hypertension. If there is a pulmonic and aortic stenosis, their intensity will decrease, and you may only actually be able to auscultate a single S2. Right bundle branch block, once again, will increase the interval. And then there's a phenomenon called reverse splitting that can actually happen with the left bundle branch block, because then the aortic valve is delayed and it follows the pulmonic closure sound. The other systolic sounds that you will actually read about or auscultate is an ejection clicks. These are typically associated with the bicuspid valves. You can actually hear them in the native valves. The bicuspid valve is the sound of the opening of the valve. Now, okay, what happened this thing? Can we go back a little bit? What happened here? Yeah. Next slide. Most ejection sounds will disappear as the valve gets thickened and less pliable, because the valve excursion is limited in those conditions. There are non-ejection clicks, which typically is associated with mitral valve prolapse, and it may or may not be followed up by a systolic murmur. Next one. S3 and S4. S3 is normal, as we mentioned in children. In adults, it's associated with ventricular dysfunction, systolic heart failure. S4, again, it can be auscultated with the augmented stethoscope capabilities, but with the normal stethoscope, you will typically not hear it unless there is ventricular stiffness with the left ventricular hypertrophy or hypertension or ischemic ventricle. It is the sound of the left atrial contraction, basically atrial contraction. The left is more prominent one. Next one, please. Diastolic sound. Now, this is very important to remember. Diastole should not have any sounds between S2 and S1. Diastole is a silent interval. So listen for, they actually say that listen for sounds in systole and listen for silence in diastole. So any sound that is the systolic murmurs or some of the systolic additional sounds may or may not be abnormal, but any sound in diastole typically indicates some sort of abnormality. So one of the most common and most famous is the high-pitched opening snap of mitral valve with mitral stenosis, particularly if there's a rheumatic mitral valve disease. And the distance between the opening snap and the second heart sound actually can indicate the severity of the mitral stenosis, because the interval narrows as the mitral stenosis gets worse. And then again, as the intensity will decrease if the mitral valve is getting more stiffer and calcified. The other sound you actually can hear in that area is a high-pitched sound, which is associated with constrictive pericarditis. It's called pericardial knock. You can rarely hear a tumor plop with atrial myxoma. So these are actually the opening snap has two differential diagnoses with associated with this. It's like 3 is mitral stenosis, constrictive pericarditis with the pericardial knock or tumor plop of the myxoma. Cardiac murmurs. Cardiac murmurs are basically audible vibrations due to increased turbulence, and the timing of the type of murmurs is defined by the timing within the cardiac cycle. If they occur in the systole, it's called systolic murmur. If they occur in the diastole, it's called diastolic murmur. And if they occur continuously, the continuous murmur is that can be heard in systole and diastole altogether. And then the intensity and duration of the murmur is basically determined by the pressure gradients across the chambers, which generates the murmur. And it varies, with the hemodynamic status. Intensity is typically graded on the scale of 1 to 6. You can palpate murmur. A thrill is a palpable murmur, which is typically means that the murmur is going to be at least grade 4 or higher. The other very important thing when you're auscultating a murmur is, apart from location, is radiation and response to certain maneuvers like dynamic auscultation. And we'll talk about that in a minute. Timing of the cardiac murmurs, as I stated, systolic, it occurs in systole, diastolic, it's in diastole, and continuous, it basically goes from systole to diastole. Now, systolic murmurs can be actually divided into 3 different types of murmur. Early systolic murmur is a murmur of acute myocardial regurgitation. It's a murmur of ventricular septal defect, muscular septal defect, which particularly in the absence of pulmonary hypertension, and then the tricuspid regurg murmur in the absence of the pulmonary hypertension. Mid-systolic murmur is typically associated with the aortic valve disease. Aortic stenosis can be valvular, where the valve itself is thickened, calcified, and narrowed. It can be supravalvular. There usually is some sort of membranous structure just above the valve that creates a physiology of stenosis. Coarctation of aorta is associated with this type of murmur, and subvalvular stenosis or hypertrophic cardiomyopathy is associated with the mid-diastolic murmur. Other conditions are like any type of hyperdynamic state, like if there's an increased flow because of fever, because of aortic regurgitation. So it's systolic murmur, but you actually hear it in aortic regurgitation because there's just a hyperdynamic flow. There's a lot of blood flowing across the valve. The complete heart block can actually do that because it is during the widened RR period, there is increased ejection of the blood. Dilatation of the aorta in certain aortic inflammatory condition and atheroma, if there's a significant atheroma, that can cause enough turbulence for you to auscultate a murmur. Pulmonic, again, is obstructive phenomena, pulmonary stenosis, which can be subvalvular or the valvular, increased flow, and related to shunts like left to right shunt. And dilatation of the pulmonary artery will cause enough turbulence in the blood that you can actually auscultate a murmur. Next. Late systolic murmur is typical. One of the most common thing is with the mitral valve prolapse, but in acute myocardial ischemia, when you have a dysfunctional acute dysfunction of the mitral apparatus, papillary muscle ischemia, that can actually cause a late systolic murmur. And then tricuspid valve prolapse, which is very much less and difficult to auscultate, can cause a late systolic murmur. Hollow systolic murmur, that murmur that basically starts from the just after the onset of the S1 and goes all the way to the second heart sound, is a MR and TR. When they are chronic and established, you can actually auscultate a hollow systolic murmur. And then left to right shunt of the ventricular septal defect can actually generate hollow systolic murmur also. Diastolic murmurs, similarly, early diastolic murmur, aortic regurgitation is a classical example of early diastolic murmur. It actually heard at the around the upper left sternal edge, just below the aortic valve. And there are a number of other conditions that can cause aortic regurgitation. And then in a lot of connective tissue diseases, the aortic regurgitation is actually an associated phenomenon. Like the most common cardiac abnormality in terms of valvular abnormalities you see with the connective tissue diseases is aortic regurgitation. So you may actually see auscultate an early diastolic murmur. Similarly, with the pulmonic regurgitation, you can actually auscultate a early diastolic murmur with isolated or associated with tetralogy, fellow VSTs, stenosis. They will actually also cause sometime diastolic murmur in early phase. Mid-diastolic murmur, classically, is a murmur of mitral stenosis. It's a Carey-Coombs murmur, is a very classical murmur of acute rheumatic fever in mid-diastole at the apex. And increased flow across non-stenotic mitral valve with severe mitral regurgitation, VST, PDA, high output states of complete heart block, you can actually hear a mid-diastolic murmur also. Similarly, with tricuspid stenosis or increased flow across the tricuspid valve, left or right atrial tumor can actually generate a mid-diastolic murmur because around that point, the myxoma may be prolapsing in through the valve and creating a functional stenosis. Other classical murmur is Austin-Flint murmur. It is a mid-diastolic murmur of severe aortic regurgitation because this intensity of aortic regurgitation starts to close the anterior leaflet of the mitral valve, and that actually generates a murmur, which is a functional murmur, basically. Next slide. Late diastolic sounds or murmur is a classical pre-systolic accentuation of mitral stenosis murmur. And this is associated with the atrial systole. If the patient is in sinus rhythm still, it means the P wave is there and the atria will be contracting with that. Then mid-diastolic murmur of the mitral stenosis will accentuate at the pre-systolic phase because of the atrial systole. And this is one of the classical findings of auscultation in patients with mitral stenosis, particularly rheumatic mitral valve disease. And then the Austin-Flint murmur of severe aortic regurgitation will also accentuate because of atrial systole. Continuous murmur is the murmur that basically starts in systole and you can keep auscultating them in diastole. It's associated with classically the patent ductus arteriosus that fails to close after the baby is born. Coronary AV fistula, if they are large enough, will actually create that. Ruptured sinus of valsalva of the aorta will actually create a continuous murmur. Aortic septal defect, the aorta sort of drains, the defect drains into the ventricular atria from the aortic valve and aortic wall. And the venous hum is like a humming sound you can actually hear if there is a big catheter in the veins and there's hyperdynamic state or any type of hyperdynamic state. Very rarely, if you have a large coronary artery, which is stenosed in the proximal segment, you will actually hear a sound, which is like a humming sound. Memory shuffle of pregnancy, like there's increased blood flow in that area, so you will likely hear that. And then branch stenosis of the pulmonary artery and other, congenital abnormalities, ASD with mitral stenosis or AV fistula in the intercostal vessel, they will likely give rise to a continuous murmur. These are rare, but known cases. This is actually a brief mention that whenever you are looking for mitral valve prolapse, you want to auscultate the patient standing up and in the squatting position. When the standing, the venous return decreases and the ventricle becomes much smaller and the prolapse will occur early in systole. The click will move closer to S1 and the murmur will also move. With squatting, it is the opposite effect. The click moves away and the murmur moves away from S1. So these dynamic changes will actually help you diagnose whether this is mitral valve prolapse or not. So in terms of dynamic auscultation, number one is you want to auscultate patient after, at the end, inspiration and expiration. Ask them to breathe in and hold it and breathe out and hold it. Typically, left-sided murmurs will accentuate with end expiration during expiration, and the right-sided will accentuate during inspiration. Valsalva maneuver will actually decrease the length and intensity of most murmurs, the two exceptions being hypertrophic cardiomyopathy and mitral valve prolapse. And once, in the recovery phase of Valsalva, the right-sided murmurs tend to return to baseline earlier than the left-sided murmur. We also test patient with the exercise test on the treadmill test or the isometric hand grip exercises to assess the impact on the murmur intensity and duration, and that is actually can be helpful in diagnosis. And then positional changes with the standing up and squatting position. The hypertrophic cardiomyopathy and mitral valve prolapse are the two conditions that actually can be differentiated based upon those. Next. The other thing is actually you have a systolic murmur with mitral regurgitation and aortic stenosis, and patient has irregular heartbeat. So one thing that actually helps the diagnosis just by auscultation is that in mitral regurgitation, there will be no change from beat to beat in the intensity or duration of the murmur, whereas with the aortic stenosis, there is beat to beat variation in the intensity of the murmur, and that actually helps that which valve is affected. Then there are pharmacological intervention that can be used. A lot of these are actually used much less frequently these days because we have a lot more non-invasive ways of assessing the valve. Before that was available, a lot of these pharmacological tests were very common to assess for the changes in the murmur and the response of the murmur to determine the underlying diagnosis. One of the things that sometimes is done is that you inflate a cuff on the both brachial arteries above the systolic pressure, about 20 millimeter higher than that. This will augment the murmur of some AR, MR, and VSD. These three things because there is more backflow towards the ventricle. This is the depiction of what we talked about. This is S1 is the first heart sound, second heart sound. This is pre-systolic exit. This is, actually this is like, the late diastolic murmur, like as a pre-systolic accentuation. This is this is actually a late systolic murmur. This is diastolic accentuation, yeah. So this is the continuous murmur. that will basically start just after the S1 and go up to the S2. That is a sort of a crescendo, decrescendo murmur seen with the aortic stenosis. This is a murmur of pulmonic stenosis, which actually is a sort of crescendo, decrescendo, but it continues through the aortic component of the second heart sound and goes up to the P2 closure. This is the early diastolic murmur of the aortic regurgitation. This is a classical murmur of the mitral stenosis, then an opening snap. The distance between the S2 and opening snap will narrow as the mitral stenosis gets worse. And this is typically you can actually hear with Austin Flint, something like that. Also, this is the S3. So S3 typically occurs after the opening snap, and this is a mid-diastolic murmur. This can be the Austin Flint murmur. And let me just move this up here. And this one is a continuous murmur. This is a patent ductus arteriosus. It starts in somewhere in systole and goes all the way into diastole. And this is diastole, systole, so it's always goes through the both phases. So in terms of that, auscultation, those was a brief review, so very basic review and refresher. I'm going to switch gears and talk about a different topic. It's called acute coronary syndrome. Acute coronary syndrome has 4 components: unstable angina, non-ST elevation MI, it's called non-STEMI, ST elevation MI or STEMI, and sudden cardiac death is also part of the spectrum, because a significant minority of the people, their first clinical presentation of a myocardial infarction or acute ischemic event is ventricular fibrillation or sudden cardiac death. Next. This is basically an evolution of our understanding of how the atheroma develops. Now we know that it's a combination of immune response, inflammatory reaction, smooth muscle proliferation, and lipid storage disease. They all take part in the development of an atheroma that can lead to acute coronary syndrome. Next paragraph. And this actually diagram basically starts with the normal artery, all the way goes to the artery with the significant atheroma. The very first thing that actually happens in the body, in the vascular structure and function, when there is development of atherosclerosis, is development of endovascular or endothelial dysfunction. The endothelium of the vessel will start functioning abnormally. And one of the abnormalities is that their production in response to nitric oxide varies, starts becoming abnormal. That is the very first thing that will happen. The other thing is you can actually consider LDL as a particle that is circulating around your blood vessels, looking for a weak spot in the endothelial structure where it will attack and start accumulating in the intimal areas. So endothelial dysfunction will lead to development of atheroma, and over time you can actually see, you will see the intimal thickening, and that all the way goes to the point that you actually have significant narrowing of the coronary arteries. At various stages of that, there will be erosions and ruptures of the endothelium that will cause activation of the clotting cascade and will cause development of thrombus in the lumen. Now, luckily, most of those are not significant enough to cause any clinical symptom, but what they do is it ruptures and heals, and it actually keeps causing more accumulation in the intima and thickening of the intima with increase in the size of the atheroma. When the rupture is significant enough to cause a significant amount of thrombus to accumulate, then it will determine if the clot obstructs the flow completely or partially, or if it obstructs and reopens immediately. If it obstructs it partially and opens immediately, like completely, but opens reperfuse immediately, you will have non-ST elevation MI, or in some condition, if it's very brief, may just be unstable angina. But if it is a complete occlusion, then you will have ST elevation MI. Remember, both can actually, the first symptom may be ventricular fibrillation, because a sudden ischemia can trigger ventricular fibrillation. So sudden cardiac death may be the very first manifestation. Next slide, please. This is again the same thing. It's unstable angina, non-QMI, Q-wall MI, which is STEMI. So if somebody will have a chest pain, it's a flow diagram. How do you will get to a working diagnosis? Then you go to the EKG, cardiac biomarkers, and the final diagnosis. And difference between this, and this is going to be the degree of occlusion and reperfusion of the vessel. That will determine whether you end up with one or the other. All these three can trigger the fourth one as sudden cardiac death, because ventricular fibrillation may be the first manifestation of any of these. This is, once again, it's a sort of some more description of the same phenomena, whether you go from unstable angina to ST elevation MI, and it really depends on how much acutely thrombus has developed and how much occlusion is present in the respective coronary artery. That will determine whether you get unstable angina to non-ST elevation MI to ST elevation MI. And once again, it's very important to remember that any one of these will actually result in ventricular fibrillation and sudden cardiac death. Next slide, please. So management of ST elevation MI is the one I'm going to touch briefly. So one of the most important things we discovered is that aspirin is actually a life-saving drug for people who are starting to have ST elevation MI or any type of MI, but particularly ST elevation MI. So in the ISIS-2 study that was done in late 80s, they compared streptokinase, one of the fibrinolytic, with aspirin. So there were three arms of the study: aspirin alone, streptokinase alone, and combination of aspirin and streptokinase. So what they actually found, that aspirin alone was as effective in opening up the arteries as the streptokinase. It's almost similar impact, and the combination of the aspirin and streptokinase was much better. And one of the reasons of that combination works better, or worked better also, was that streptokinase fibrinolytic is when you administer them, or the body's own system get activated after a thrombus occludes the coronary artery, is a dynamic phenomenon. So there is occlusion, reperfusion, and part of that dynamics is activated platelets. Aspirin inhibits platelets, and that actually gives streptokinase time to reperfuse and then keep the artery open, because the major culprit in that dynamic of occlusion and reperfusion and reocclusion is the platelet activation, and aspirin actually inhibits that. So aspirin is one of the most life-saving drug you can give somebody if they start having a heart attack. How do you give aspirin? You basically ask to take non-enteric coated aspirin, give them at least like 2 baby aspirin or 4 baby aspirin. That will be 100, each is 81, so that will be like 162 or 324 milligram of aspirin. Ask them to chew it because it gets absorbed much quickly through the mucosa as compared to if you just swallow it. So that is actually one of the most important things to do if you suspect somebody is having a heart attack. There has been concern that a lot of time people present with an epigastric discomfort, which may be a heart attack, or they may actually have been starting to have GI bleed because of peptic ulcer disease. But overall, if you are suspecting, if there's a reason to suspect there's maybe a heart attack and you're concerned about the GI bleed, just give it to them. Aspirin may actually save their life. It's not going to cause enough problem with the GI bleed to cause any serious harm, and it can be taken care of. But if it's a myocardial infarction, it will actually save their life. The second thing to consider is oxygen, but it's actually there is we used to give oxygen. Anyone know you're having a heart attack, let's put them on oxygen. 2 liters, 3 liters, 4 liters, depending upon them. But nowadays, the recommendation is that you check their O2 sats, like if they are below 90, please supplement the oxygen. But if they are above 90 and they're not like dyspneic, as per se, try not to give them oxygen, because there are studies which show that people who have good baseline O2 saturation but given supplemental oxygen, because of some sort of oxygen toxicity, they actually had higher troponin leak as compared to the people who did not get oxygen, which basically indicates that there might be a higher burden of myocardial damage. Other thing to do is a pain control. Morphine is the typically used. Morphine also is a vasodilator, can help in people in pulmonary edema. But then again, there are certain concern about routine use of that. So use it very cautiously. Nitrates, nitroglycerin, the sublingual nitroglycerin is the one you want to give the patient. The reason you want to give a sublingual nitroglycerin, because it will get into the system immediately and be effective immediately. The only time you need to be careful about giving sublingual nitroglycerin is if somebody has inferior MI that involves the right ventricle. If it's a right ventricular infarct, you can actually cause hypotension and bradycardia in those people. And if the patient is dehydrated and their blood pressure is on the low side, to avoid that, because that can cause sudden drop in the blood pressure that can make the situation worse. Other group is the beta blocker. The thinking about the beta blockers, the evidence keeps evolving and changing. Initially, the idea was don't give beta blockers, and everyone was actually getting IV beta blockers, and now we try to restrict it to people who have hypertension while they're actually undergoing an evolving myocardial infarction, or if they are tachycardic with a reasonable blood pressure. Those are the people you can give IV beta blocker. Metoprolol 5 milligram is a typical dose used, but be careful if patient is in florid heart failure, because in the initial phases, if you are in class 3 or class 4 heart failure, administration of beta blockers can depress your ventricular function further. Statins are one of the more mainstay of the treatment of any type of coronary artery disease, and we try to administer them acutely. And then the ACE inhibitors also, depending upon the patient's LV function. If they have anterior wall myocardial infarction, irrespective of the LV function, if there's no contraindication, we like to give them ACE inhibitors, at least temporarily. If they have LV dysfunction, then that may be a lifelong ACE inhibitors or ARBs or Entresto these days, which is a combination drug, will be a lifelong therapy. Now, one of the most important thing that we need to do about the ST elevation MI is the reperfusion therapy. We need to open the artery, because that is the one thing that is going to make a difference whether patient ends up with the LV dysfunction and heart failure or a normal LV or patient. Basically, it's a difference between life and death. Next paragraph, please. So there are, two options available when you come over the reperfusion therapy. One is the fibrinolytics, and the other one is PCI, coronary intervention, PTCA, and stenting of the culprit vessel that's causing the myocardial infarction. And these two words are thrown around a lot of time in these circles. Minutes mean myocardium, like you need to hurry. Every minute counts, and more you delay, more myocardium is at jeopardy. And time is muscle, the same thing. Delay in the treatment mean dead muscle. This is actually the management of ST elevation MI in a lot of countries like United States is a big deal. This is one of the things that is observed. It is, managed through the federal government and local government initiative, and everyone is actually held accountable in every case. So to give you an example, if I'm on call for the ER to take care of these patients, so basically we use PCI as a primary mode and angiography and angioplasty stenting. So there's a team on call for the cath lab. 24 hours a day, 7 days a week, if the hospital is providing the service. Everyone, irrespective of whether it's 9 a.m. or 9 p.m. or 3 a.m. or 3 p.m., everyone who's supposed to be on call and covering the service is supposed to be in the hospital within 30 minutes of the call being initiated. It used to be that patient will be picked up and brought to the emergency room, and they will have electrocardiogram, 12-lead EKG there, and then the determination will be made. But now in almost every community, there are advanced cardiac care ambulances which are equipped with performing EKG at the spot and transmitting it to the hospital where they're taking the patient. So when the patient is being picked up, that call can be put out for emergency team to go to the hospital, and we actually have 30 minutes to be there. And all these times interval which are managed, the patient 5 minutes after symptom onset, dispatch, EMS on the scene, how soon they should be, and then when they got the EKG, they got to the emergency room, how soon they need to get another EKG, and how soon decision has to be made about the treatment, and how soon, if you're going to give them fibrinolytic therapy, how soon this needs to be administered, and if you're going to do PCI intervention, how soon they should be in the cath lab and how soon it should be open. They are all observed and monitored, and if there is any delay, everything gets looked up by a committee in the hospital, and the person who's responsible for that delay in the series of these steps has to answer, but what happened? Why did they not do their task within this defined amount of recommended time? Typically, if you are taking the patient to the hospital that provides the service with the PCI, what we call is a door to balloon time. Like now, these days actually become the first medical encounter to balloon time. Like the first time the EMS saw the patient and did the EKG to the time that we opened up the artery with the balloon has to be 90 minutes. Under 90 minutes. If it goes above 90 minutes, it gets looked at, okay, what went wrong? It gets looked at irrespective, even if it's 30 minutes, to see, okay, what worked, what didn't work. But if it goes above 90 minutes, it's definitely going to be a committee that's going to sit down and look at it. Okay, what happened here? Why didn't we meet the 90 minutes? Now, if you go to a hospital that does not have the services of the cath lab and PCI, and you plan to transfer the patient to a place where it has the services, the time allowed is under 120 minutes. They just add 30 minutes for the transfer time. But it has to be, so if I'm at a hospital that doesn't do intervention and I want to send somebody to a hospital that does intervention, it is my responsibility to make sure, okay, the weather condition, transport availability, whether patient is going to go by ground, by air, everything is in a way that patient will hit the other hospital and get the intervention done within 120 minutes, under 120 minutes, basically. If there is a delay to that, then we go to fibrinolytic therapy. And if the PCI is not available at the hospital, we do the fibrinolytic therapy. TPA is a classical one, but we have TNK, different, modification of the fibrinolytic agents is available. The second concept associated with that is a door to needle time that is associated with the fibrinolytic therapy. So if the patient arrives to the hospital, the ER, at say 9:30, and we are going to give the fibrinolytic therapy, we have excluded all the contraindication, we've made sure that it's going to be safe, the therapy should be started within 30 minutes. It's a door to needle time. If it's more than 30 minutes, that is going to get looked at again, and why there was any delay to that. Next slide, please. So this is actually the concept about the time and the in-hospital mortality. On the X, you can see the time from door to drug, that's the fibrinolytic therapy. And on the Y-axis, you see the in-hospital mortality, the difference in the time. And this is about 85,589 patients. So it's a large patient sample. So it's the lowest mortality is 0 to 30 minutes. So as you add minutes, the mortality goes up. Same thing happens with the PCI. 43,801 patients is a large, sample volume. As the time goes, the time is around the x-axis. As the time increases, the mortality increases. So the time is muscle, minute means myocardium is what we actually live on. Next paragraph, please. Next one, slide. So this is actually meta-analysis difference between the outcome is between primary PCI and fibrinolytics. And this is just shows that, if you actually look at from days to randomization to, outcome, this actually is, the mortality is higher with the fibrinolysis and the primary PCI does better. This is, and all other, cardiogenic shock, death, and heart failure or reinfarction. And the benefit of the primary PCI is primarily, due to decreased incidence of reocclusion that happens with fibrinolysis and decreased intracranial bleed or any major bleed, because fibrinolysis is associated with higher incidence of intracranial bleed or any major bleed. Those are actually the two components. Reocclusion and less bleeding rates are the one that actually tilt the balance towards the primary PCI. And that is sort of standard of care in a lot of Western countries. If you have that. So I think this is, about enough about the myocardial infarction. And so it's actually, we have evolved. The treatment of myocardial infarction has evolved rapidly. Can you go back? So it wasn't until 1980s that we established that the thrombus in the coronary arteries is the one that caused the myocardial infarction. Because before that, the debate was the thrombus formed because atheromas slowed down or cut off the blood supply. Then the thrombus is the result of myocardial infarction is not the cause of myocardial infarction. But after a convincing data presentation and publication in New England Journal of Medicine in 1980s, it was basically determined that the thrombotic occlusion is the primary cause of myocardial infarction, ST elevation myocardial infarction in the vast majority of the cases. So we actually moved towards trials for fibrinolysis and then followed the PCI. And prior to that, myocardial infarction, particularly anterior wall myocardial infarction, meant that most patients will be readmitted with congestive heart failure. Another thing is the patient typically spent a week or 2 weeks or more in the hospital as a part of the treatment of myocardial infarction. Initially, patients were not allowed to turn themselves in the bed. The nurses will basically rotate them. They were not allowed to do anything for first couple of days after they had heart attack. So this was there's a lot of hodgepodge things which were being tried, but it was after 1980s that we actually got the clue that what causes it, and there was a rapid development of technology, drugs, training skills that has gone to the point that most myocardial infarction people who get primary PCI these days, they actually go home within 48 to 72 hours. And I was talking about the technology, the same thing which we did, different thing we do in the term of primary PCI, we do angioplasty and stenting, but we also have different modalities about sucking the clot out, thrombectomy, which always had mixed results in the coronary arteries, primarily because of the size and diffuse nature of the disease. But that actually helped us develop technology to do thrombectomy in other areas. And can you show this next slide? So now we actually have one of the treatment for the pulmonary embolism is available, is that in a very sick patient, we have devices that can suck the clot out. So this is actually patient, I'm just showing, we took care of it like 2 days ago. This is a catheter, we call it a pigtail catheter, because if you look at it without the contrast, it has a, like a curved ending. It's called a pigtail catheter. This is coming from the femoral vein up into the pulmonary artery, and we are injecting the contrast. So if you actually see that there is very little blood going into the lungs, it just cuts off because there's a big chunk of clot around here, similarly around here. And now one of the options we have is that we can put a big catheter up into the pulmonary artery and literally suck the clot out. And the next picture, please. This is the picture of the same patient on the right lung, like about 30 minutes later. So this whole perfusion is back to normal. His oxygen requirement was, he was 100% like full non-rebreather mask and saturating at 80%. And after this, he was actually saturating at 98% on 6 liters. And this is actually the technology in one field helps us to develop treatment in the other fields. That's basically what I'm trying to indicate. Thank you very much. Do you have any?
Thank you for your mentorship and teaching, Dr. Adi. We will now begin our Q&A session. My name is Hamza. I'm a student at Seton Hill University, and I'm in the 8-year BSDO program with the Lake Erie College of Osteopathic Medicine. To start off our Q&A, for the students who weren't here last week, how many years long was your residency and fellowship after internal medicine?
Well, after internal medicine, the fellowship, typical cardiology fellowship is 3 years. It's called general cardiovascular medicine. And if you want to do interventional cardiology, you have the option 1, 2, or even 3 years these days. So if you're talking about in the United States, if you're talking about a typical straight path that you come out of medical school, start residency, you're going to do 3 years of residency, then you're going to do 3 years of general cardiology. and then you'll do 1 to 3 years of interventional cardiology. Typically, it's 1 to 2 years, but in certain cases, people who want to follow a path to, research also, that they may have to do an additional, year of the training. Now, there are certain other pathways. There's a pediatric adult combined program that probably goes into 5 years training, if I understand. So, so it's not a, it's a reasonable amount of time. It's not.
All right. Thank you very much for that answer. What type of procedures do you perform as an interventional cardiologist?
I typically do the coronary interventions. I do peripheral and venous and arterial both, and do structural, like, TAVR for the aortic valve, or Watchmans for the left atrial appendage occlusion. So those type of procedures.
All right. These questions following will also relate to you being an interventional cardiologist. After what point does one become comfortable performing high-risk procedures like STEMI procedures?
Actually, the training program where I am, like in the United States, the most training program are actually good enough with the high volume and good, mentors, that you basically are supposed to be ready on day one. I mean, learning curve is there. I mean, everyone has a different learning curve. And I think the best advice for any trainee is that never be afraid to ask for another opinion or help, because that will save a lot of trouble down this road if you don't do that. So.
And out of curiosity, when you're first learning how to maneuver the catheters, do you do that with patients, or is there something else you learned that with?
When I started my training, it was primarily patients, but nowadays they do have, a lot of system, like, you can do training of maneuvering catheters and different things, which, if there's some new catheter, new technology comes out, we utilize that also. But the real learning is in the patient. I mean, in the machine, like, you have these sort of system where you can simulators where you can actually simulate different maneuvers and everything, but this is not the human body. Every human body reacts differently to everything you do. So real learning is going to be on the patient.
All right. Thank you. Can you explain what proximal and femoral axis are, and what are the pros and cons between the two?
Say that again.
Can you explain the difference between what proximal and femoral axis are, and what are the pros and cons between the two?
Proximal?
Or distal, my bad. I might have written it wrong.
No, I think the axis to do a coronary angiography these days, there are two axes which are typically used. One is the radial axis, like wrist, we can do the ulnar or radial artery, or the femoral artery. To do the femoral artery, you have to make sure that you're basically going right in the middle of the common femoral artery. So the landmarks we use is the inguinal ligament, which is a very misleading landmark, because every individual has that inguinal crease at a different level to the inguinal ligament. But what we are trying to do, and ultrasound is used a lot of time, you can do without ultrasound also, the percutaneous access, when you basically just get a needle into the artery to get the access. The idea is to try to get in the middle between the inferior epigastric artery and the bifurcation into superficial femoral and profunda. So that is considered the safest femoral access. Radial or ulnar access is actually considered much safer than the femoral artery, because it is much easier to control the access after the procedure is done and to obtain the hemostasis. So one of the major issue we face these days is not the damage to the heart arteries when we are doing the procedure, because the skills set and the technology has become so advanced that is becoming very rare. access site bleeding has been the major issue. And there is pretty convincing data that if you use the radial access or the ulnar access, the risk of bleeding is actually significantly lower than the bleeding from the femoral access. So radial access is our default access for coronary angiography. We basically aim to go to the radial artery or ulnar artery, and we only go to the femoral if we have to use a very large bore catheter for certain special procedures, or patient has severe spasm that cannot be taken care of with some medications, or there is an anatomy is as such, there are tortuosity or things that the passing the catheters or wires is not going to be safe to do that. Those are the only exception when we go down the femoral these days. Otherwise, radial is a default access.
Thank you very much for that answer. This following question is something from my own experience. I've been in the cath lab before during a STEMI operation, and at the end of the procedure, it was discovered that the patient had suffered brain damage. Can you explain why this happens during these procedures and what is done to counter the effects of brain damage, both to prevent it and to deal with it after it has already occurred?
I think the brain damage because of the procedure can happen. It's very extremely rare because of the procedure. And there are two reasons that can happen. Number one is patient has some tendency to bleed, and they got a lot of, we have to, when you do the procedure for like a STEMI, when you're doing intervention, angioplasty, stenting, whatever, you need to make blood quite thin. So we give them large doses of heparin or Angiomax, which is bivalirudin alternative to heparin, and sometimes additional antiplatelets, IV, like 2B3A agents, agrostat, apixaban, those type of thing. And that can actually cause bleeding, but that's very rare. It is there, but it's extremely rare. The other thing that can actually happen is the catheter. When you have atherosclerosis in the coronary arteries, you're going to have atherosclerosis in a lot of other places. Your aorta is going to be diseased. So the catheter going in and out of the aorta, up and down, will basically universally scrape off some atheroma, microparticle that go up to the cerebral circulation. Sometimes the load is significant enough, or there are larger particles that get dislodged and they can cause a stroke. And that can be converted immediately into ischemic stroke because patient is getting large amount of blood thinners. What's more common than some of those scenarios is that one of the presentation of intracranial bleed is also, they come with ST elevation changes or LC elevation MI. We have seen people who actually had intracranial bleed and they fell, basically passed out. They got to the hospital, they did an EKG, they have ST elevation MI. So everyone assumed that they had a cardiac arrest and spontaneously reperfused their, rhythm stabilized spontaneously. So they actually go to rush to the path of doing the PCI, and then you find out that, well, they actually also had intracranial bleed. So that can be, it's rare, but that can be happen. So, I mean, it is, risk is there whenever you do anything in the body. Whenever you move the catheters in the aorta, that something will dislodge or cause problem with the stroke, but it's luckily is extremely rare.
Thank you very much for that answer. Have methods for cardiac oscillation changed over time? Do you think anyone can learn to listen to oscillations, or does the skill require a special sensitive ear?
Well, I don't think you require a special sensitive ear, particularly these days, because there are stethoscopes available that can actually augment the sound. And there are, gadgets available that you can do the phonocardiogram recording and auscultate with the augmented sounds. So yes, you can do that. Basic technique and method remains the same. The skill set over time is actually declining because when I started doing residency, there was a time echocardiography was there, but a lot of other modalities were not available. Now, echo is pretty universal. A lot of time before, when I get counseled to see a patient, before I see the patient, they've already ordered an echo and echo is already there. So I actually go to see the patient after seeing his echocardiogram. So I know what I'm listening to, my brain doesn't have to work hard enough to say, oh, what murmur is that? Because I've actually looked at his valves already. I know what murmur is going to be there if there's going to be a murmur. So that does affect the skill set of the trainees and the practicing physician. There is actually an interesting study that in the cardiology field, the skill set is highest among the graduating fellows, and as the time goes by, the skill set of auscultation, like making a diagnosis just by auscultating something, that skill decreases over time because, as I said, one of the privilege and the advantage and disadvantage of practicing in the United States is a lot of time when you as a consultant go see the patient, they have done so many scans that you basically look at that, you know everything what the patient's going to have. You're just trying to put some of the things together if there's any change, which is actually sort of a disservice if you order so many tests for the patient that you're taking away your own skills. But that is the reality of the medicine, particularly in certain parts of United States. And the exam system they have is also very different than it used to be in the United Kingdom, because they still have the clinical component of the exam for their membership exam, MRCP. You have to have, a skill set of examining the patient or auscultating the patient without looking at all their tests. So it's a mixed bag. But anyone with enough training can basically learn to auscultate and find what is going on.
Thank you very much for that answer. This next question will be coming from one of the students, Kashifa. If you want to ask the question now, you can go ahead.
Hi, Dr. Ali. My name is Dr. Kashifa, and I am an international medical graduate from Pakistan. My question is if there is any contraindication to percutaneous coronary intervention.
Say that again, the last part.
Are there any contraindications to percutaneous intervention?
Well, yes, I think so. The contraindication is number one, if somebody has active bleeding, then unless it's an emergency, well, I'll give you an example. If I have a patient who came in with non-ST elevation MI is medically stabilized and they also have GI bleed, I'm not going to do the coronary angiography and intervention, because post-intervention, stenting is the one. They need to be on dual antiplatelets for a significant amount of time. So that can make things up. So what I need to do is I will stabilize, and the patient will get endoscopy. And if they find a bleeding point, they can actually take care of, inject it, ligate it. They will do that. And following that, they will go for that. So the bleeding risk of bleeding or active bleeding is a contraindication. Number two, which is a very important thing to look at these days, is renal function. If somebody has advanced kidney disease and they have non-ST elevation MI, but their ejection fraction is normal on the echo, they are clinically stable, then we do a lot of, back and forth with the patient in the family, because depending upon the level of your kidney disease, contrast used for the coronary angiography may mean that you will end up on dialysis temporarily or permanently. So that is a very important thing. So all of these are relative contraindication. And the third thing, which is very important, the third thing which is important is the compliance. It's very easy for me to do an angiogram and put like a bunch of stents in every artery, but I need to make sure that patient is going to be compliant enough to take the medication. Because if they're not going to take their medication, I'm actually not helping them. I'm actually expediting their demise, because the chances of having a major heart attack if they stop their antiplatelets prematurely is significant. And that will actually, the outcome of that is much worse than somebody who's had their own de novo non-ST elevation MI particularly. Fourth thing is quality and quantity of life left. So that is the very important thing. You know, if somebody has terminal cancer, they're only going to be expected to live a few months. So unless they have intractable angina that nothing controls, in that which case we sort of can do a palliative angiography and intervention, limited intervention to the only thing that may be causing the problem, with clear understanding that it is not going to prolong your life, it's just going to keep you comfortable, and it is very rare to do that. That is a very important thing to consider. Like if somebody has 4 weeks to live and they have a non-ST elevation MI or even ST elevation MI, but their pain and all those things have been controlled and they're comfortable, you're actually not doing any service to them if you just go ahead and do some fancy procedures and put a lot of stents in or do something. So those are the things, you know, you have to do. So there are a lot of relative contraindication. You have to make sure the procedure is going to be safe. They're going to come out better than when they are going in as compared to coming out worse. Those are the things. But then there are a quality of life and the compliance issues also.
Thank you very much.
The next question I'll ask again is, what is mitral stenosis and what is the normal prognosis for patients with early detection?
The mitral stenosis is basically narrowing of the mitral valve when it gets to the point that the valve becomes so narrow that the atria is not able to push enough blood to the ventricle and the back pressure builds up. You develop pulmonary hypertension. That can actually cause severe tricuspid regurgitation, that can cause RV dysfunction. So those all, you know, there's a whole sequence of events that leads to mitral stenosis. So it's a narrowing of the mitral valve. Outside the, you know, so the countries with majority of the middle and lower income countries, which is 80% of the world population, rheumatic valve disease is still the #1 cause of the mitral stenosis. In other countries with like considered higher income countries, it's more of a degenerative disease because rheumatic fever is virtually has been eradicated in most of those countries. So it's a degenerative valve disease that actually caused the mitral stenosis. Prognosis in either case is pretty good as long as you actually have an early detection and treatment initiation.
Thank you, Dr. Ali. I'm going to pass that over to Robin for the rest of the Q&A.
Hi, Dr. Ali. I'm Robin. I'm a PhD student at Johns Hopkins School of Medicine. I have a few more questions for you if you have some more time.
Sure, sure.
The first question is, what is restrictive carditis and what causes it?
Sorry, I didn't hear that.
What is restrictive carditis and what are the causes?
It's called restrictive cardiomyopathy. Basically, there are some, you know, infiltrative diseases that can cause the myocardium. Basically, your myocardium becomes stiff. And that creates the whole spectrum of problem leading to the heart failure. So restrictive myocarditis is one condition. Then you have a constrictive or restrictive, you know, constrictive pericarditis. They sort of have similar type of presentation. Your ventricle is stiff. It does not have the capacity to accommodate the blood coming into it without increasing the left ventricular pressure and diastolic pressure to the extent that you develop congestive heart failure, and that spectrum eventually will lead to the weakness of the heart muscle, pulmonary hypertension, mitral regurgitation, dilatation of the ventricle. So there are, you know, different reasons, like the eosinophilic myocarditis is one of the eosinophilic cardiomyopathy is one of the major things. It's very rare, and different countries have different, Chagas disease can cause myocarditis that can present with different type of manifestation, but it's a whole spectrum, because unless any cardiomyopathy is treated, it will become systolic dysfunction and dilated cardiomyopathy, because that's the path of deterioration it follows. Hypertrophic cardiomyopathy also, it goes from the restrictive to, it actually starts with the sort of impaired relaxation physiology. When the ventricle has impairment of the relaxation, it doesn't relax enough. And the cascade of events will get to the point when this becomes a restrictive physiology. It's not the restrictive cardiomyopathy, but the physiology is the same, that any amount of volume is too much for the ventricle to handle. So back pressure will build, you get pulmonary hypertension, you get pulmonary edema, you will start getting impact on the right ventricle. So the whole cascade of events will do that.
So many things can go wrong with such a vital organ. Can you explain why right-sided murmurs tend to return to baseline faster than left-sided? Does that have to do with the general anatomy of the heart?
Yeah, I think it's a part of that is that the right side is a low volume, structure. So it gets worse with the small fluctuation in the pressure, low pressure structures or low pressure changes, and it gets better also, it will do that. So that is one of the probably reason. The one thing is very important to understand, right ventricle is, as compared to the left ventricle, and the left-sided structure, right-sided structure are extremely understudied. We have just started over the last 10 years paying attention that, okay, well, right heart is as important as the left, because if you look at the number of researches, articles out there, number of the, studies, a lot of it just focused on the left side. The right is like the stepchild of cardiology. The right ventricle is like, okay, well, its only purpose is just to pump the blood to the lung. It doesn't do anything. Well, it's actually a very vital organ. Changes in the right ventricle will determine outcome of the transplant, outcome of the lung transplant, outcome of the heart transplant, and outcome of a lot of things we do for the left ventricle is extremely dependent on the right ventricle. So one of the things that precludes simple lung transplant is going to be if the right ventricle is abnormal. Because there's physiological changes that will put extra strain immediately post-transplant. And if the right ventricle is not normal, is not able to handle that, those people can literally die on the table, operating table, or they can actually die afterwards. Heart transplant also is very important. They actually look at the pulmonary hypertension is one of the determinant whether you're going to get the heart transplant or not, because your RV will fail if you have too much of pulmonary hypertension. When we do the valvular surgeries, one of the things, well, the most important thing is the pulmonary hypertension is a great determinant of whether you will get the intervention or what the outcome is going to be, because your right ventricle will fail if you have a severe pulmonary hypertension. You correct whatever you want to do, correct, but you are not able to come off the heart-lung machine because your right ventricle is just gone. So that's actually, so the right side, it's been a stepchild. Recently, it's been a lot of interest, a lot of equipment and treatments, mechanical treatments are being developed to take care of the right side of the heart now, as compared to what we had for the left side for decades.
I'm glad the other side of the heart is getting the attention it deserves now. The rest of my questions are a little more general. So given that the incidence of cardiac disease is increasing, especially in the United States, what are some lifestyle changes that have led to this?
I think actually, well, if you actually look at overall, so the incidence may be increasing in certain areas. The incidence of, fatal outcome from heart attack is decreasing. the lifestyle is basically one of the good things that happened in the United States, that eventually they realize that smoking is bad. So now I'm sure that more than 90% of the public places don't allow smoking. You can go to a restaurant without smelling tobacco, in most places. I mean, there's still some areas that do that. I worked for a while in Kentucky, and it's actually interesting. I actually saw people who started smoking at the age of 4 or 5. Because in the family, nobody cared. They just put the cigarettes around, so the kid will just pick it up and start learning how to smoke. And by the age of 40, they were vasculopath. They had disease of every part of their body, from the stroke to the limb ischemia to the heart attack, you name it, they had, because all they did. And there were people who still argued that you doctors made it up, smoking does nothing bad. I mean, you guys just say it. But that is actually one of the good things happened, is that the smoking has gone down, so that has a positive impact. But on the other side, exercise is very variable depending upon where you live. I mean, there are cities, if you have if your BMI is between 25 to 30, there are states and cities in the United States where you go and you think, well, man, I'm the slimmest guy in the world, and then there are other areas you go and say, I'm not going to go out because I'm so obese, because it's just the behavior is so different in different areas. So the lifestyle about the diet and how they exercise is actually one of the important factors. Smoking is one of the good things that has happened, that has become, people still smoke, but it is not this cool thing to do in high school also. Like kids, everyone is smoking because it's the coolest thing to do. Everyone's smoking in the parties because it's the coolest thing to do. I think that is a positive impact. But on the other side, stress of the life, your diet, and, then depending upon access to your smart, phone and the social media access, making you spend more time on that instead of going out and doing some physical exercise, that actually impacts the things. It's a mixed bag, I think.
So speaking of regional differences in people, can you describe what the general population you work with in El Paso is like? And how do you deal with patients who desperately need cardiac interventions but are not insured?
Well, El Paso is a predominantly Hispanic population. And I say there's a significant number of people here who are American citizens who work in El Paso, but they live across the border in Mexico because the cost of living is, much less there. They have a very high incidence of diabetes among them and hypertension. Their dietary habits are really like, I'm from Pakistan, so their dietary habits are what a lot of people in Pakistan and in India, like their food are very, spicy and oily and all that stuff. So we do see much younger people with cardiovascular disease here, and hypertension and diabetes is a very high incidence. And I think the other part, that how we deal with the people who are resistant to getting help, you just have to talk to them, and it really depends whether they want to listen or not. It's very hard. I mean, there are people who will agree to do everything, and 2 weeks later they're like, oh, I'm not going to show up, I don't need it. So El Paso has a higher incidence of cardiovascular disease just because of the population and the risk of, the incidence of diabetes and obesity and hypertension among them, and then their dietary habits. And there's higher incidence of smoking in El Paso as compared to certain other cities also, I'm sure.
As an interventional cardiologist, is it difficult to manage a work-life balance? Are you on call or do you have hours?
Yeah, I think it's the on-call is still, it can be pretty busy, and then you have to try to strike a balance, but it can be very difficult. As I said, the on-call, one of the things is that when you're on call for the emergency room, basically you have to be available. So you have to be at the hospital in 30 minutes when the specific call comes. So that can actually, mean that you get up, you come home after a very busy day and get called back again and again and again can happen. So you can spend all night doing emergency cases. So yeah, I mean, that's there. So it's, it's the choice we have to make. I mean, it's not, I mean, you can actually, you have the option, okay, I'm not going to take the ER call. So a lot of people at certain stages start doing that. Okay, well, I'm not going to take the emergency ER call. So there, other people take that.
I guess that could also dictate where you live, because if you're having like a longer commute to work, you might not even be able to go home after your shift if you're on call.
Well, I think what we do is like people, and it's sort of the hospital does not mandate it, but it's an unwritten rule that please live somewhere where you can be in the hospital within 30 minutes, because if you're not in the hospital in 30 minutes, so it's the way, we talk about the door to balloon time. So the patient who shows up in my hospital, their door to balloon time, unless they're transferred from some other facility from outside the city, has to be within 90 minutes, under 90 minutes. If I show up, I'm the medical director of one facility, but even if I show up, instead of 30 minutes, I show up at 40 minutes, but everything goes smooth and door to balloon time is still under 90 minutes, I still have to give an explanation, well, what happened? Traffic, this, weather, or I was busy with another patient someplace or something happened. But if the door to balloon jumps above 90 minutes, then there's a whole different level of explanation people have to give. So it's like, what happened? Why it took so long? So that's why, you try to live somewhere where under the extreme circumstances, you're still able to get to the hospital within 30 minutes.
So our very last question is, what advice do you have for students that are interested in pursuing cardiology?
Do it if you like it. I mean, it's worth it. If you really like it, yeah, do it. I mean, you actually have a lot of options these days. I mean, there was a time when, if you say you want to work part-time and you don't want to do this, you don't want to do that, it was considered, well, you're not interested in working at all. But the things are changing. So yes, I mean, you can actually work out certain things that, okay, well, you'll only do this up to a certain extent. And you will actually still, but you don't actually have to be interventional cardiologist. There are other subspecialties which are there's a lot of advances in every field of cardiology. So there are a lot of things you can do. And, but, if you really like it and you want to do it, then do it. It's worth it. I mean, this, the whole medicine, if you want to do it if you like it, because medicine is not like, it's not going to be a side business. It's if you want to do it well, you have to do it as your main work thing. So that's the important thing.
Thank you so much for your time today and answering all of our questions.
Oh, you're welcome.
Thank you so much, Dr. Ali. We really appreciate you taking the time to answer all of our questions today and taking the time again out of your day to mentor us. I'd love everyone to please give a warm thank you to Dr. Ali in the chat box for this incredibly informative session. Thank you.
Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live, and you'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat right now. And now for our next session dates, which will also be posted throughout our social media outlets. So be sure to follow us at TeleShadowing. Our next session will be next Saturday, September 17th at 12:30 p.m. Eastern Standard Time with another mentor mentoring us in cardiology. And TeleShadowing is having all cardiology sessions for the month of September. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.